hyperkalemia treatment, as probably all of you know, start with the first steps to stop any potassium supplements. This include oral potassium supplements and IV potassium supplements. And this include the potassium, any potassium in IV fluid or IV potassium supplements, and any potassium, don't forget TPN, that's need to be stopped as well. So don't forget about that. The second step is to stop any offending agent, any drugs that can potentially cause hyperkalemia. We need to stop that, and I will talk about that soon. And then after that, as you know, we talk about cardiac stabilization with IV calcium, shifting techniques with moving potassium from extracellular space to intracellular space, and then third is elimination of potassium through the kidney. How do we apply this in real world settings? As I still see a lot of mistakes in doing that. These steps we need to do with all cases of hyperkalemia. But cardiac stabilization and shifting and elimination, do we need to do it with all hyperkalemia cases regardless or not? This is what I'm going to discuss in this video. Before we start, if you would like to receive a summary of this video, please subscribe to my Substack page. And please let me know in the comments if this video will change the way you're managing hyperkalemia in inpatient settings. Let's start. So what's hyperkalemia? Because it seems there is no consensus on the cutoff value after which we say this is hyperkalemia. Some facilities say hyperkalemia is if the potassium is above 5 milliequivalent per liter, and some say it's hyperkalemia if potassium is above 5.5 milliequivalent per liter. I personally goes with the 5.5. That's when I start the treatment of hyperkalemia. But that does not mean I should just sit when I see the potassium is creeping up 5, 5.1, 5.2. In all cases, I think we need to do step 1 and step 2 where we stop any potassium supplements and to stop any offending agent or drug. But for the treatment for cardiac stabilization, shifting, and elimination, I usually consider hyperkalemia above 5.5. Let's talk about treatment. Now, the moment I get potassium level above 5.5, the first thing I do immediately is to obtain a 12-lead EKG. Please remember that very well. And I place patient on telemetry if they are not on telemetry yet. Now, why the EKG is important? Because if this EKG is normal or similar to baseline, as some patient will have an abnormal baseline EKG, the next things I do is I question is this is a true hyperkalemia or not, or what we call false hyperkalemia or pseudohyperkalemia. So normal EKG, the next thing I ask, is it possibly a pseudohyperkalemia? And I only think about pseudohyperkalemia if I don't see any reason why the patient will have hyperkalemia. Let's say I have a young guy who just had an appendectomy, no previous medical history, not on any medication, and next morning I see their potassium, for example, 6. There's no reason for them to be hyperkalemic. I look, are they receiving any potassium supplements? Do they have any abnormal kidney functions? Are they on any medication? If I don't see any of that, then I should suspect pseudohyperkalemia. And before I start on treatment, I should recheck potassium level to verify that result. On the other hand, if the EKG is abnormal, and when I say abnormal, it has EKG changes that can be triggered by hyperkalemia, this is true hyperkalemia regardless and need immediate treatment. I will discuss these EKG changes very soon. So what could potentially cause artificially elevated potassium level? First, and the most common one, is hemolysis in the blood tube related to blood drawing techniques. And second, severe leukocytosis with a blood count above 50,000. And third, severe thrombocytosis with a platelet number above 1 million. And both we can see them in polycythemia. Leukocytosis, we can see it in some leukemias as well. So what are the hyperkalemia related or EKG changes? Hyperkalemia can cause wide ranges of EKG changes. The earliest manifestation that you could see is the famous peaked T wave, which I'm sure you all read about. And on the other hand, the terminal rhythm that you could see in severe hyperkalemia right before they go into cardiac arrest is the sine wave. So sine wave is the rhythm right before they go into cardiac arrest, whether from VFib, asystole, or from PA. But there are also a lot of other changes, include wide complex tachycardia, bradycardia, and bradyarrhythmias. And when I say bradyarrhythmias, that include sinus bradycardia, high-grade AV block. And when I say high-grade AV block, I'm talking about Mobitz type 2 block and third-degree block. AFib with slow ventricular response with bradycardia. So pay attention to that. That can happen from hyperkalemia. Also, hyperkalemia can mimic STEMI, cause ST elevation mimicking STEMI. A lot of these people go to the cath lab, they have no coronary artery disease, you check their potassium is critically high. So remember that. Also, I think P wave flattening and increase PR interval. And very important, don't forget that bundle branch block, whether right and left or bifascicular block, all these can be related to hyperkalemia. And very important to remember, they don't have to appear in chronological order. You don't have to see peak T wave first and go in order. You could start with wide complex tachycardia or sinus bradycardia or high-grade AV block, or they could present with bundle branch block or ST elevation only. Let's talk about the severity of hyperkalemia because that will dictate the steps of treatment, as we will see soon. Hyperkalemia can be mild, moderate, and severe. Let me start with the severe. Any potassium, any hyperkalemia that associated with EKG changes is considered severe regardless of how high the potassium level is. So if the potassium 5.5 with EKG changes, this is considered severe. So remember that EKG changes makes the potassium or hyperkalemia severe. That's why it's important to obtain EKG immediately. Also, any potassium equal or above 6.5 milliequivalent per liter is considered severe. On the other hand, moderate is anything between 6 and 6.4 milliequivalent per liter is considered moderate, and anything from 5.5 to 5.9 is considered mild hyperkalemia, as long as they don't have EKG changes. This will dictate the moderate, mild, and severe will dictate the steps of treatment, as we will see now. One important thing before we dig into the treatment, I want you to remember the chronicity factor. People who are known or have chronically elevated potassium, they are less prone to any serious complication from hyperkalemia, including EKG changes, and the treatment may not be as urgent as those with acute hyperkalemia. For example, hemodialysis patients. These patients, they have chronic hyperkalemia. They can have potassium of 7.5, and they don't need emergent treatment other than just hemodialysis. They tolerate that very well. Let's talk about mild hyperkalemia. Now, mild hyperkalemia, I'm going to remind you stop any potassium supplements and stop any offending agents. Now, when I say offending agent, there is a long list of medication that can cause hyperkalemia, but some of them are well known to cause that, and we need to remember those and stop them when there is hyperkalemia. Famous ones: ACE inhibitors and ARBs, angiotensin receptor blockers, potassium-sparing diuretics like aldactone, spironolactone, or amiloride, heparin, antibiotics like Bactrim, trimethoprim, sulfamethoxazole, and pentamidine, NSAIDs, non-selective beta blocker like labetalol, immunosuppressive like cyclosporins and tacrolimus. And remember, these two medications, please don't stop them on your own. If the patient has a transplant, whether kidney transplant or heart transplant, the last things you need to is to mess up with their medications. So consult with their transplant doctor about these medications before making any changes. Now, believe it or not, in mild hyperkalemia, this can be adequate, is to stop any offending agent, stop any potassium supplements, and then repeat potassium maybe in 12 to 24 hours, and most of the time the potassium will be better. Now, as you see, you don't need to do any of the shifting techniques or any elimination techniques. Now, in hemodialysis patients, you need to consult nephrology to perform hemodialysis on their regular schedule. There is no urgency. Remember, they can tolerate hemodialysis patient, they have chronic hyperkalemia and can tolerate high potassium level. Now, if you feel too nervous, feeling I need to do something about this, I cannot leave this potassium, it's 5.9, all you need is to do some elimination techniques, which is giving a 1 or 2 doses of IV loop diuretics, which I will explain in details now when I talk about moderate hyperkalemia. Let's talk about moderate hyperkalemia. Potassium here is 6 to 6.4 milliequivalent per liter, and by definition patient, there are no EKG changes associated with this. I want to remind you again, stop any potassium supplements and stop any offending agents. Now, hemodialysis patients, they need to be dialyzed same day. Now, for us, still we don't need to do any cardiac stabilization or any shifting techniques. So the only thing we need here is to do elimination of potassium via renal route through the kidney using IV loop diuretics. And let me explain how do we do that. So we give a dose or two of IV loop diuretics. For example, furosemide 40 to 80 milligram IV. I may give a dose now and monitor their urine output, and if there is no adequate urine output or no adequate response, I may repeat the dose. So definitely we need to monitor their urine output and then recheck potassium K level in 6 to 8 hours. Now, I'm giving diuretics here, so it's very important that I pay attention to the patient volume status. Is the patient hypovolemic or euvolemic or hypervolemic, have fluid overload? Now, if the patient is hypovolemic, it doesn't make sense that I give IV loop diuretics right away. Instead, what we need to do is provide volume resuscitation first and give the loop diuretics seconds. Now, with euvolemic patients, we give the loop diuretics and monitor their volume status, and if we feel they need fluid, we provide fluid resuscitation or volume resuscitation second. And for hypervolemic patients, it's easy. You just provide with IV loop diuretics. And the loop diuretics has to be given IV. Don't give PO. We need a quick response. So furosemide 40 to 80 and sometimes 100 milligram IV. Monitor their urine output. Recheck potassium in 6 to 8 hours. Volume resuscitation has to be done with isotonic solution, and I pick either lactated ringer or plasma light. Please avoid normal saline. And the reason that normal saline can induce normal anti-GAP metabolic acidosis, which can worsen hyperkalemia. Now, you may wonder about that lactated ringer has potassium, and it's counterintuitive to use lactated ringer on hyperkalemia. But remember, lactated ringer has 4 milli equivalent of potassium in each liter, which is very small. Please do not stop lactated ringer because of concern of hyperkalemia. If the bicarb is less than 22, instead of using lactated ringer, we can use bicarb drip. And we only use bicarb drip, not bicarb amps. Amps are very hypertonic and will osmotically drag potassium from intracellular to extracellular space, causing worsening hyperkalemia. Isotonic bicarb drip can be used in volume resuscitation if the bicarb is less than 22. And that will help us with volume resuscitation and shifting potassium. So we hit two things with bicarb drip. And if you watch my IV fluid course, bicarb drip can be made by 3 amps of bicarb mixed in 1 liter of free water or D5W. And very important to remember that some may feel, oh, I cannot give the bicarb drip more than 100 cc an hour. No, when you give isotonic solution or volume resuscitation, you need to give it in boluses or very fast rate. You can do the same with bicarb. I can give it up 500 cc to 1000 cc an hour. So don't be scared to infuse bicarb drip quickly. Let's move to severe hyperkalemia. And we said EKG changes with any elevated potassium is considered severe hyperkalemia or potassium above 6.5, equal or above 6.5. So again, we stop any potassium supplements and we stop any offending agents. In these patients, we need to perform all the techniques we have. Cardiac stabilization with IV calcium, plus shifting techniques, plus elimination. In hemodialysis patient need emergent dialysis. You don't need to think too much. Just call nephrology and perform immediate or emergent hemodialysis. And of course, you need to provide cardiac stabilization and shifting techniques, but the elimination can be only through hemodialysis. Let's talk about cardiac stabilization. We use IV calcium. IV calcium is available as calcium gluconate or calcium chloride, and calcium gluconate can be given 3 grams IV over 10 minutes and through peripheral access. Calcium chloride can be given 1 gram IV over 10 minutes through central access because it's very irritant. Now remember, very important, here we don't just give the calcium and leave. We have to see the stabilization of the rhythm on the monitor. And remember, IV calcium work for 30 to 60 minutes. So you may need to do more doses. Some patients we've done 3, 4, 5 doses to stabilize them. So it's not just once and done. You give it, you monitor the patient, and if there is stabilization, be prepared that in 30 to 60 minutes, you may need to give more of this calcium. Let's move to the shifting techniques. And as all you know, we use insulin, beta-2 agonists, and bicarb drip. Let's talk about insulin. Here we use only IV regular insulin. Sub-Q insulin has no role. We need something to work quickly. So please do not use sub-Q insulin in critical or severe hyperkalemia. Use only IV regular insulin. And I usually use 10 units of IV regular insulin. Now, if the blood sugar above 250, there is no need to provide any dextrose. If the blood sugar less than 180, I usually give 2 amps of D50. And if the blood sugar between 180 to 250, I usually give 1 amp. And don't forget to check or continue to monitor patient blood sugar. Remember, insulin effects can stay or last for 4 to 6 hours. So if there is any delay in definitive or elimination therapy, potassium is high, you still can repeat it in 4 to 6 hours. Let's talk about beta-2 agonists. And I usually don't go there unless I have a crashing patient. I'm trying everything possible to eliminate or to lower potassium level. And I usually use albuterol. But the trick here, most people use very small dose. Here, if you want albuterol to work, you need to use 10 to 20 milligram of albuterol nebulizer through nebulizer. So a big dose of albuterol. Don't give 2.5 or 5 and expect it to work. And even with this big dose, albuterol induce small shift in potassium that lasts 2 to 4 hours only. So in 2 to 4 hours, if the potassium is still high and the patient is crashing, you can repeat this. The next things, if the patient is having low blood pressure, bradycardia, and hyperkalemia, it makes sense that we use epinephrine, right? Because epinephrine improves the blood pressure, improves the heart rate, and can cause shifting of the potassium intracellularly. And that's the case where I think about epinephrine. So don't forget about it. It can be useful in such cases. Let's talk about bicarb drip. And bicarb here has to be given as a drip. Hypertonic bicarb should not be used. And the reason for this will osmotically drive potassium out of the cells, causing worsening hyperkalemia. So only bicarb drip. And as we explained, we can do that by mixing 3 amps of sodium bicarb in 1000 cc of D5W or free water. Bicarb drip should only be used if there is metabolic acidosis, the bicarb level is less than 22, and only if the patient is either hypovolemic or euvolemic. Please avoid in hypervolemic patient. And remember, it can be given as fast as 500 cc to 1000 cc an hour. And remember that once the bicarb level start going high, you need to discontinue bicarb drip, and hopefully by that time, potassium level start to come down. Let's talk about elimination. And when I say elimination, I'm only talking about renal elimination through the kidney. We have not talked about GI, and I'm not going to talk about it because it's a slow way of potassium elimination. If I need to use, if I will think about anything through GI elimination, the only one I would use is sodium zirconium. Do not use K-oxalate, sodium polystyrene, or patiromer. They are not effective in acute hyperkalemia management. Now, if the patient is on hemodialysis, perform emergent hemodialysis. Now, for non-hemodialysis patient, also keep dialysis in your mind, but you're gonna try to save them from that dialysis. So you're gonna try as aggressively as possible to get the potassium out through the kidney. And the way we do that is to give aggressive regimen of diuretic from multiple classes. We're gonna use a loop diuretic plus a thiazide diuretic plus a carbonic anhydrase inhibitor. So we could use, for example, furosemide here, for example, 100 milligram or 120 milligram plus a 500 milligram of IV chlorothalidone plus 500 milligram IV of acetazolamide. And you can increase or decrease the dose, but I recommend that you go as aggressive as possible because you're trying to get the potassium out. You need to monitor their urine output because we expect them to start making urine like crazy. And if you don't see any significant or minimal, you see minimal urine output or the urine amount that you don't expect, prepare for hemodialysis. On the other hand, if you see large urine output, please monitor potassium frequently, because soon the potassium will start dropping and soon you may be in hypokalemia. Now, with this large amount of urine, how about the volume status? That's what we discussed in moderate hyperkalemia. What do we do here? This is a very large amount of urine we expect and hope for, so we need to watch for volume status. As we discussed in moderate hyponatremia, for hypovolemic patients, it doesn't make sense I give them this very large diuretic mix while they are still volume depleted. We need to resuscitate them with volume. We said lactated ringer or plasmalite, and you need to give maybe for these people 2, 3, 4 liters if needed. And if the bicarb is less than 22, use bicarb drip. Again, 500 cc to 1000 cc an hour, because I see still people very afraid to use more than 100 or 150 cc an hour in bicarb drip. Euvolemic patients, we go ahead and bomb them with this diuretic regimen and then resuscitate them, monitor their urine output, and then replace that volume with lactated ringer or plasmalite, and if the bicarb less than 22 with bicarb drip, and here just give them that diuretic bump. And remember, very important, that you monitor potassium closely. Monitor urine output, your eyes on the rhythm or the telemonitor. Now, if this doesn't work, the next thing is hemodialysis. And as I said, if you don't see the patient is making the amount of urine you expect or little amount of urine, just put dialysis catheter and call nephrologist to perform hemodialysis. Now, one last thing we could throw there, if there is a recent use of ACE inhibitors or ARBs or NSAIDs or beta blockers, is to use Fludrocortisone. I know a lot of you probably never used in hyperkalemia, but if there is severe hyperkalemia, there is a recent use of this medication, you can give 0.1 to 0.2 milligram, you give it PO. At the end, if you found this video useful, please give it a like and share it with your colleagues. And to receive a summary of this video, please subscribe to my Substack page. The summary should be delivered to you the next day after the video is released. Thanks for watching.